I'm going to introduce our first speaker. So Professor Satchit BALSARI is a good friend. He is an assistant professor in emergency medicine at Harvard Medical School and the BIDMC in Boston. He's also with the Global Health and Population at Harvard T.H. Chan School of Public Health. And he's a faculty at the Harvard FXB Center for Health and Human Rights. He teaches various courses, among which this is one of them with Professor Jennifer Leaning on the societal response to disaster and war. He's also leading work coordinating with India in the Indian Health Data Network. Satchit, we know Satchit from our previous work together at the Academy. So at HKAG's DPRI, Satchit's helped us to formulate our scoping review and formulated the work that goes forward at the Institute. So he's been familiar with different disasters, settings, preparedness work across the world. So over to you, Satchit.
Thank you, Kevin. Can you hear me okay? Great, fantastic. Thank you for the invitation, and it's always wonderful to be back in the CCOUC fold, albeit unfortunately remotely this time. But we'll make the best of these emergencies that we are in, which is what we'll talk about today as well. You know, Kevin alluded to these series of cases that a whole bunch of us from around the world are working on to look at how to strengthen emergency and disaster risk management using the WHO Health EDRM framework as sort of the overall guidance for this work. The expected outcome of Health EDRM, according to the WHO document, as we know, said that countries and communities having stronger capacities and systems across health and other sectors, resulting in the reduction of health risks and consequences associated with all types of emergencies and disasters. And depending on where we stood in the last few years and what part of the world we were in, what that disaster might have meant or looked like to us would be vastly different. Even in Asia, what now seems to be a very long time ago, we would have thought about SARS and MERS in South Asia. You would think about hurricanes and floods. In California, in the United States, we think about wildfires. And then, of course, 2020 comes around, and all of us are thinking about the pandemic. Against these drumbeats of sort of natural disasters and public health emergencies, the world, of course, continues to have vast amounts of forced displacement from wars, from climate change. And these displacements do not end up being temporary, as was imagined by the humanitarian system many years ago, especially in the aftermath of World War II. What we have found is that this idea that refugees can be welcomed into refugee camps and then eventually settled elsewhere, either in the host communities or in repatriated back to their countries of origin or elsewhere, doesn't work. And we found that refugees end up having a protracted stay in the host communities, often for several generations, as we have seen in Dadaab and are now about to witness in the Rohingya camps in Bangladesh as well. We chose to study the health workforce in Lebanon because it seemed to, unfortunately, witness all of these various types of disasters that I talked about, and in a very short amount of time. Here, the background of sort of the displacement from the Palestinian, Iraqi, and Syrian refugees coming into Lebanon is the background, and on which are political emergencies, disasters, and then, of course, the pandemic. During these large-scale emergencies and prolonged conflicts, the WHO document guides that there are going to be significant health consequences that pose challenges to the delivery of even the most basic of health services. And we understand this. We read this in the news every day. Health systems must therefore adapt and prioritize services, including assistance from national and international actors to address the health needs of affected populations. Essentially, we're talking about local capacity being completely overwhelmed and saying, look, how are you going to work with international partners to sustain your capacity to deliver healthcare not only for the refugees, but to your own populations as well. And more recently, this has been extremely challenging in Bangladesh, which saw 1 million refugees coming in from Myanmar over the last couple of years. Lebanon is very interesting, even historically, as we sort of delve into what is happening in Lebanon, to understand that in the first half of the last century, the 1943 National Pact defined what power sharing in Lebanon was going to be. And the three sects that you have in Lebanon are, of course, the Shia, the Sunni, and the Mennonite Christians. And their confessional system of government allocates power equally to these three groups. It favored the Maronite Christians for a very long time, despite the growing Muslim population, because of that original National Pact. Why is this important for public health? Because to date, a lot of the data that you see in Lebanon about people, about populations, are all guesstimates, because the last official census is sort of frozen in time, and that was in 1932. 1975 to 1990, Lebanon witnesses a prolonged sectarian war. Many who could flee fled, and several of us in Europe, especially around France and the United States, know that there is a vast expat population of Lebanese professionals, including healthcare providers, that are in these countries, and they sort of fled during the 1975-1990 spell. Iraq and Syria were part of this ongoing conflict then for 15 years. The Syrian occupation of Lebanon actually ends only in 2005. 3,500 physicians had left to train overseas by then. In the rebuilding that then happens, there is a brief period of economic stability where there is a robust public health system of over 1,000 primary care centers that are set up in Lebanon. The wide variation in the quality of service that they provide, of course. 3% are owned by the government, and the rest are run by civil society organizations and nonprofits. A subset of these primary healthcare centers, which end up playing a very important role in what we're about to study, are credentialed as Ministry of Health primary healthcare centers. They meet eligibility criteria that the ministry sets out, and of course, then receive both benefits and are able to see certain kinds of patients who are remunerated by the ministry. The financial model is a hybrid model. The Ministry of Health is sort of the last resort if all other insurance expires. 70% of the Lebanese population was still sort of paying out of pocket, despite a fair number of public and private insurance schemes being available. What you then notice is that doctors started returning during that phase of relative peace. Some of them were now highly specialized and highly trained abroad. To attract them back, there were a series of pull factors that were strategically instituted in Lebanon. This was the capacity to practice with the same standards of technology that these doctors were used to, evidence-based medicine, research capacity, opportunities for collaboration, and including personal factors like good schooling for their children, the ability to live comfortably and safely. Many of us know these wonderful researchers and physicians now across Lebanon, and especially AUB, that a lot of us have worked with in disaster and humanitarian circles around the world. There were growing remittances back to Lebanon, but all of this seemed to be a little out of sync with the government's capacity to deliver sort of the dream that a lot of Lebanese as well as Lebanese expats had for the community. The development is, of course, asymmetrical, as is expected in many of these scenarios, with the folks that are coming back and that are highly specialized and trained concentrated in the urban clusters in Lebanon, where primary healthcare, rural healthcare start suffering a little bit. The nurses, initially there's a boom of nurses. There's an oversupply. Many then start leaving to go abroad. And then there is a huge shortage in the primary health centers, especially in rural Lebanon. Job satisfaction, about sort of 10 years in, is increasingly low in the primary healthcare centers. 40% respondents in a national study said that they intended to quit in 1 to 3 years. So these are doctors and nurses. Interesting side note, pharmacists are in oversupply in Lebanon and continue to be. They have one of the highest per capita pharmacists in the country. What then happens is unprecedented in the world in terms of the percentage of the population that changes in a brief amount of time because of the Syrian influx. 2011, 12, 13, you see a rise in 1.2 million. The population of Lebanon is 1.2 million, right? So that's a 25% increase in the population of Lebanon in 2 to 3 years. This is completely unprecedented anywhere in the world. If we're talking about developing health workforce capacity, within a short period of 2 to 3 years, the country is expected to expand its healthcare delivery services, as well as food, water, sanitation, by 25%. Lebanon withstood this shock in the early years, and it did so largely because of 3 or 4 sort of key observations. The funding mechanism was very flexible. The Lebanese government partnered with the international community and delivered care both through the public and the private sector in all kinds of permutations that were possible. The international community essentially then serves as a de facto payer for the expanded services. There was also integration of refugees into the system. There was no large refugee camp in Lebanon, as we saw in the surrounding countries with the Syrian refugees. The Syrians in Lebanon are largely self-settled in the communities, and despite Lebanon not acknowledging them as refugees, Lebanon is not a signatory of the Refugee Convention, so denying them formal refugee status. It, however, allowed the Syrians to not just go to specialized healthcare centers meant for Syrian refugees and refugee camps, but allowed them to access the infrastructure of its primary healthcare clinics and to some extent the secondary and tertiary clinics as well. But payment for the primary care services was possible in the initial years, and capacity was also ramped up, and more clinics were being built with the international aid. You begin to see a vast growth in the network of primary care centers across Lebanon. There are mobile centers set up as well. In 2015, the Lebanon Crisis Response Plan was launched, international aid comes in, and the goal in 2015 for the LRCP is to serve 3 million people, majority of whom are then Syrians and some Lebanese as well. This starts to buckle very shortly. From 2009 to 2014, there was a 173% increase in the number of nurses that are trained in Lebanon, but working abroad, so people leaving. Over 60% of nurses by 2014 were under the age of 35, indicating that there is alarmingly poor workforce retention. As demand continued to rise, there was significant lapses in the quality of care. Over 40% of Syrian households had at least one member with chronic illnesses, right? That then needed to also access secondary care, which was not available. The strain on the healthcare system causes it to buckle, so much so that the most recent LRCP that goes out is still targeting 3 million people, but of which a significant portion now are local Lebanese who have not been able to access care because of the supply-demand mismatch and what is happening to the economy in Lebanon. Against this, you have the October 2019 economic crisis, where there's currency devaluation that directly results in less compensation to the healthcare system for the services they were providing. That results to cuts in wages, cuts in jobs, has a destabilizing effect, as it always does when there is an economic downturn, because the first knee-jerk reaction of the health system is to cut wages or to let workforce go. That only results sort of in a temporary fix. You then have an oversupply of providers that are around. And when demand quickly peaks up again, it is impossible to then recruit all these folks back because the costs are so high. This is a sort of a cycle that has been seen around the world. And it's extremely important at this stage to try and stabilize these salaries. This was 2019. Following 2019, there was then the COVID pandemic, the blasts in Lebanon, that entirely destabilize the system. What you then begin to see is an exodus of physicians. Resident physicians especially cannot finish their training or trying to leave abroad. A lot of the healthcare professionals, the highly specialized ones that had come to Lebanon, now find it unsafe and economically unviable to continue to live there, and so also start going back. And despite the pandemic, they are finding jobs back in the countries that they had initially been trained in. And so you find not only that the nursing attrition that was already in play, but you now sort of begin to see a large physician attrition as well. And so there we stand in April 2021, despite a country, a nation, a society doing its best to absorb a surge in their population by 25%, unable to withstand these cascading crises, and especially sort of the final whammy after the refugee influx of the economic downturn, the bomb blasts on the port, and the pandemic are completely crushed. I'll pause there, Kevin.
Thanks, Satchit. Do you have a second part? Because I know you've been doing some work, doing interviews and stuff. Do you want to share this later on, or?
I'm sorry, say that again.
I was just asking because I know you've been doing some work interviewing key stakeholders. Were you going to tell us a little bit about it, or we should talk about it in the Q&A?
We can talk about it in the Q&A. Yeah,
that's great. Yeah, cool. Thanks, Satchit. I think it's a very comprehensive and rich sort of context for us to start off today and the discussion. Some of you may be aware of the Senpai Framework and how it evolved into become signatory and how it is. So I think for those of you who are following the Senpai Framework closely, nations were debating whether to include conflict into the Senpai Framework. And in the last minute, because of the political issues debating the disaster prevention or the mitigation aspects into conflicts, it eventually were not featured in the Senpai Framework. But unfortunately, we've seen increasing in local conflicts in different parts of the world. Lebanon, it's a very rich and interesting case. I've been trying to use this for my MPH courses that I teach as well. And I think Satchit was able to summarize all the challenges in just 15, 20 minutes. And that's very nicely put. I've not seen any question just yet, but I think we can sort of open this if any of the panelists in Sonoya and Bettina, if you want to chip in, please feel free to do so. But maybe I'll start off the discussion with Satchit. So you mentioned about the push and the pull factor for physicians, especially the highly skilled physicians in Lebanon. And in surrounding countries as well, I'm sure. And the international community trying to support this sort of influx of population with vast issues of health needs ranging from maternal child care into chronic diseases. I think, as we all know, the Syrian community are actually pre the Syrian civil war. They used to enjoy a good sort of healthcare infrastructure and services. So the challenges are vast. I just want to get your thoughts into how do you see this? What can the international communities do from the human rights point of view and from your work at the FXB Center? How could we approach this?
Thank you, Kevin, for the question. I think what is particularly challenging in Lebanon is the peculiarities of what we're faced with, right? This is an extraordinarily large refugee crisis with 1.2 million, at the very least, Syrian refugees in Lebanon. And you essentially have Lebanon that has taken in these refugees, allowed them to self-settle, and yet will not accord them formal refugee status, which hampers how UNHCR can behave and deliver care to these refugees, right? So leaving the Sendai framework aside, the framework within which the international community can best function here will be the international humanitarian laws, which become extremely difficult to interpret, and it becomes difficult for UNHCR to sort of fight this balance between playing their role in protecting the refugees, right? So their protection mission must continue, but while compromising with the Lebanese government by alluding to the refugee status of the Syrians, but not calling them refugees outright. And I think that has been constantly challenging. And the other is just the unfairness and just the bad luck of what has happened to Lebanon for a country that small to have this sort of Herculean expansion in its population. And I think there is room here to imagine a little bit more boldly in terms of unorthodox solutions, or what many would even say are reasonable solutions. I think in terms of sort of, you alluded to the interviews we had conducted. So as part of the exercise with the EDRM project that you co-lead, we spoke with a variety of key informant interviewers from Lebanon that are heads of academic institutions, healthcare facilities, response agencies that were responsible for designing some of these pull factors, as well as are now bearing witness to the push factors. And some of the recommendations of the conversations that come that arise from their analysis are the following. One is that there is urgent need to stabilize salaries, for the healthcare workforce. I think it comes down to the nuts and bolts of what's going to keep people back, and that the international community will have to step in, especially given the status of the Lebanese economy right now and their political economy as well, to retain the workforce. The other thing that has not been done at all is task shifting. When you have such vast volumes of brain drain, there have been digital health interventions, but as we've all recognized around the world, digital health interventions in medicine seem to sort of just anchor around telemedicine with poor understanding outside the clinical community of what that actually means, right? Telemedicine isn't magical. It is just your doctor using a phone. Almost everything else that your physician needs to do still needs to exist, the diagnostics, the therapeutics. The phone isn't going to fix that. But what telemedicine can do is certainly allow physician to physician consult or healthcare provider to healthcare provider consult, which then allows you to task shift to have an army of community health workers in Lebanon that can have some kind of a pyramidal reference through digital health interventions. And one of the missing groups of people that have not been tapped into for very obvious reasons, obvious not from a public health planning perspective, but from a political and protective impulse in Lebanon, is the inability to absorb or credential Syrian physicians into the workforce. So on one side, you have 25% of the population that's of Syrian origin. You have among them healthcare providers, you have among them doctors that don't even, have even had a hard time getting work permits to work in Lebanon. much less get a credential to practice medicine. And the systems are slightly different, right? They're both allopathic systems, but the Syrian doctors are not easily, even historically, credentialed to practice in Lebanon, as is the case with all our countries. There are sort of strict regulations for who can practice where, and that barrier continues to preclude at least immediate solutions, while a longer view of health workforce retention and redevelopment can be taken. I'll pause there, Kevin.
Thank you, Satchit. I think that's you've raised very important points about the possible use of telemedicine and the other issue about registration. I think that maybe that came up also in my literature review that I'm going to share with you all a little bit later on. But in the interest of time, maybe I'll just ask maybe one quick question just to round up. I mean, for our local audience, when it's not a good example or analogy, but say, for example, in Hong Kong, we had a big influx of pregnant mothers from mainland China, which has a vastly greater population than in Hong Kong. And at that time, we had to have policies responding because local mothers could not find a place to give birth in Hong Kong hospitals because of the influx in population. I think imagine that, in Lebanon, where the situation is much more challenging. Just question for Satchit, maybe it's how do you balance that local versus, because I'm sure the local Lebanese are suffering because of the population influx and the challenge to help the healthcare system. How do you balance that local versus refugee or the displaced person sort of a dilemma?
It's interesting you pick up that example, because in Lebanon in particular, the maternal and child health was given a lot of focus. The refugee maternal child health received a lot of focus and a lot of support from the international community to make sure that those outcomes remained acceptable. But that was not your question. You said, how do you balance providing them care versus the Lebanese? I think we have learned from the lessons, at least theoretically, from the 80s and 90s and what was happening in Africa, where you would sometimes inadvertently have a gleaming field hospital for the displaced refugees, recognizing only too late that you were actually providing a higher level of care to the refugees and to the host communities because the baseline health systems were so poor. From what we know and what we observe, I think it is fair to say that there is at least high recognition in the international community, in the aid community, that is not okay. And at the first sign of that happening, investments have to be made into improving the local healthcare capacity as well. And in Lebanon, it was a little bit easier, and that's exactly what the Lebanese government negotiated. And they said, we want more primary cares, give us more doctors, pay our doctors, pay our nurses, because it wasn't a separate field hospital being built for a refugee camp. So it was in fact actually easier to do that in Lebanon because it was integrated into the health system, and so Lebanon's a strengthened health system. Take the example of the Rohingyas in Bangladesh that are all on a little strip of land, Cox's Bazar, in Bangladesh, where the aid community has to ensure that as they provide these services, that these services are also open to surrounding host communities that are also dirt poor and don't have access to high levels of healthcare or education. And so there is a constant effort, very conscious constant effort to make sure that as refugee services are being provided, that services are provided for the host community. This is not in 2021. This is not just driven by the aid community. I think governments have wisened up, and part of these negotiations with the aid communities are invest in our people, and we'll give you access to the refugees. Similar situation in Bangladesh, where they refuse to let the Rohingyas be called refugees. Very, very similar story.
Thanks, Satchit. I think we can go on for days on these, but we have to stop here, unfortunately, due to limitation in time. Thank you, Satchit. Thanks for joining us, and yeah, we'll be sharing more about the case studies in the coming months, and so that we can maybe have another discussion at some point. Thanks, Satchit.
Thank you kindly for inviting us. Thank you.